That technology is now being used for multiple new drugs that are coming that work in a similar way as well. Just a few weeks ago, and at European Oncology Conference, there was a big study presented in a triple-negative breast cancer with a similar drug combination. It's a different antibody, and it's a different chemotherapy drug, but it uses the same system. So the antibody finds the protein that's only expressed on the cancer cells, and then attaches to that and brings toxic chemotherapy drug that kills not only the cancer cell, but it also has a bit of a bystander. When that cell falls apart, the chemotherapy drug is still floating there and kills some adjacent cancer cells as well. So it's really exciting technology, and we're expecting there's going to be more drugs like that as the technology evolves. But it's particularly interesting because in triple negative we really don't have a lot of targeted options, and that's probably one of the most underserved subtypes of breast cancer. So any progress there was particularly exciting. And lastly, in the triple negative breast cancers, there's been a lot of trials and attempts to use immunotherapy. Immunotherapy has been very exciting in different cancers like melanoma and lung. It has been a bit of a disappointment in the breast cancer in general, and I do get asked very often in the clinics about immunotherapy because people are seeing that it's used and it's changed a lot of treatments in different cancers. But for some reason, especially in the estrogen receptor positive, it doesn't seem that the immune system is that easily activated against cancer. But in triple negative, there's been some results and trials ongoing, and we're waiting to first get it to get some good data to support and to show us exactly which patients benefit from it. Because the response rates are still fairly low, but patients that do respond seem to have quite long response. So just identifying who will benefit before we start using it would be a great help to avoid treating anyone who doesn't benefit and avoiding unwanted toxicities. There was an access program recently in using it in combination with chemotherapy in triple negative, and there is a test that can be done on the tumor tissue that may help identify who is more likely to respond to immunotherapy if they have triple negative breast cancer. So that is something that we are increasingly asking our pathologists to add, especially when someone comes with a new diagnosis of metastatic triple negative breast cancer.